Hello, my name is Mary Adams and I'm working with Professor Jane Sandall on an HS and DR funded study looking at the strengthening of the discussion and disclosure of unexpected harm that's happened to women and families in NHS maternity care, also known as the DISCERN study. Our study team is Professor Rick Idema and Dr. Julie Hartley, also King's College London, Alexander Hazel from the University of Manchester, Maria Booker, Birth Rights, Charlotte Bevan, the Stillbirth and Neonatal Death Charity, and Maureen Treadwell from the Birth Trauma Association. So the aims of the DISCERN study: first of all, we want to generate evidence to support improvements in the disclosure and discussion of harm that's affected women in maternity care. And secondly, we want to produce support materials for frontline staff and women and families affected by these events, and to make some practical suggestions for NHS organisations and trusts on how frontline staff, clinical teams and women and families may be supported. We're using a realist approach, which briefly sounds rather more simple than it is, asks what works for who, in what circumstances, why and in what ways, and what are the consequences. So what we're looking at are the key factors and the contingencies of improvement work in this area that have effects for different sorts of participants at particular times. Just to give you a very quick sense of how our study is organised, the rationale for our design is underpinned by a realist approach, which essentially is that us developing a series of working hypotheses from literature reviews and stakeholder consultations that are then tested out, overturned or developed in in-depth ethnographic work using the usual observations, interviews and documentary analyses, and then are brought forward. What we would like to do is to translate these findings and to produce filmed and written guidance for use for a series of different stakeholders. So what is known about the involvement of women and families after a serious incident has happened to them? The evidence is quite scattered, but the Royal College of Obstetricians and Gynecologists data from 2016 suggests that 41% of families were involved in local reviews when a serious incident had happened to their baby. Shah's evidence is that only 15% of women or families were involved in reviews of severe maternal harm, and the most recent evidence from NHS resolution is that about 77% of families were notified by the trust that an incident had happened to a serious incident had happened to their baby, but only 35% were offered an apology. We do know from our conversations with our project advisors and our co-investigators, their work in charities and associations, that there's a really significant gap between what women and families expect from disclosure, candour and engagement during this period and their experiences of what happens to them in maternity care. There are some distinctive aspects of maternity care that are of note. One of these is that care trajectories are often highly variable and can be complicated. There's local variations in services, in women's choice of services, and women with complex conditions are usually managed by a series of overlapping teams, a range of professionals. Secondly, the maternity agenda itself, the safety agenda, has, as somebody has recently said, it's crucial but overly complicated. And since the National Maternity Review of 2016, there have been a series of quite notable investments, NHS investments, to drive service improvement and to reduce harm. And some of this drive is to do with the harm being really high stake in terms of emotional fallout for families and for staff, and also the costs of this harm. Obstetrics accounts for over 50% of all clinical negligence claims that are paid by. Our realist review involved 50 documents, peer review, policy and grey literature, and one of the most striking aspects of this literature is the difference between Braithwaite's distinction between work as imagined, the policy and managerial efforts to organise, fund and improve services, and the work as done, the care that's delivered directly to patients, and the weighting of this literature towards policy, policy guidance, regulation, the interpretation of regulation. There's limited knowledge of women and families' experiences of disclosure and of discussions and support during incidents. There's also limited understanding of how improvements could happen or are happening, what it actually involves. And something also notable from this literature are the very different imperatives that underpin the documentation of improvement work and the management of this improvement work. I mean, there seems to be the imperative of entitlement of harmed women, which is rarely mentioned compared to the imperative of safety improvement, learning for the future, and the imperative of risk litigation management. And there's very little evidence of the consequences of any of this improvement work. Just to give you a flavour of our early interview findings, there has been an emphasis throughout on what one informant has called the magnified moment, that point in a crisis where staff may do something or say something that could make or break the trust of the family in that service, in that team. The emphasis on the need for an authentic and a consistent advocate, someone to guide families through these very complex procedures that happen during investigations and the sorts of correspondence that they receive, and the idea of authenticity that's often set against the need for procedural and regulatory objectives, and how staff balance that is something that we want to look at carefully in the ethnography. Another issue that is coming up is the idea of coping with the grey, that even investigations don't often yield an agreed perspective, and coping with uncertainty and provisionality and finding some sort of resolution in other ways seems to be an issue that's important for women and families and frontline staff involved. Working cross-disciplinary and service boundaries we've mentioned previously, and the need for women and families to be part of a bigger picture. There are very few examples that we found of these individuals being part of service improvement or sitting on quality improvement boards or being actually involved in a trust in the longer term. Our first impressions from informal discussions and sitting in on conferences and staff training in the previous 9 months does raise some interesting questions about how disclosure work is learnt by clinical teams, and it's held within clinical teams. Who has the know-how, who has the confidence to manage that magnified moment? How do people learn it? Setting the tone as well. How is a sense of what a local culture felt by staff, and what is it that shapes that? We're starting to think about staff induction, about how legal teams introduce themselves, work in the background, but also may be incredibly influential, how PALS teams treat and relate to clinical staff, and so on. We also want so how did you know? We also want to understand how staff understand about taking risks to disclose and to discuss with families, and how those stories that often rattle around units have an influence on disclosure and discussions with patients and families. So the implications of our findings to date and the way it's going to shape our ongoing interviews and ethnographic work. There's a marked distance between policy directors and implementation work happening in this area of maternity care. We really need to understand what underpins this implementation work, what generalisable principles there are. There's also a need for an in-depth study of the ongoing practices, the skills and techniques that are developed by clinical and administrative staff and women and families when they're actively involved in understanding a serious incident and its ramifications. There's a need to capture and understand somehow those local cultures of risk and safety and blame that are felt and sustained by frontline staff involved in disclosure practices. And finally, there's a need to explore the relationships between trust teams and services in sustaining open disclosure improvement work. Thank you. So thank you for listening. If you have any questions or comments on the presentation on the DISCERN study, please add them to the comments below the video and we can read and respond. And more information is available on our website, www.discernstudy.org.